Good morning, everyone. My brief today is to talk about tibial tubercle osteotomy, the key steps. This will be mainly a video demonstration. And before I begin, I must thank the organizers of this Arthroplasty Summit for an excellent program. My name is Weber Bagaria, and I work as the Director of Orthopedics at the Sir H.N. Reliance Foundation Hospital in Mumbai. When we look at tibial tubercle osteotomy, the aim is to lift the distal bony attachment of the extensor mechanism to allow efficient knee exposure while preserving soft tissues and tendinous attachment. The key equipment that are required are 3.2 and 4.5 mm drills, 4.5 mm screws, circular wires, chisels, and an oscillating saw, usually a thin and large blade that the one that's used for patellar cut should be used for creating these osteotomies. The key steps involve an appropriate exposure, an adequate length, creating of the osteotomy, the opening of the osteotomy, and fixing the osteotomy. So in this video you'll see that we are using a medial parapatellar approach. It is extended below the tibial tuberosity, trying to preserve as much soft tissue, but at the same time allowing the adequate exposure is key for ensuring that your saw blade and your osteotomy is created appropriately. The second most important step is to ensure that the osteotomy is of an adequate length. Typically, I would like it to be an 8 centimeter by 8 centimeter long, because the larger the bone surface contact area, the greater the chances of union. It should be around 2 centimeter distal to the tibial plateau and should extend anywhere between 6 to 10 centimeter. It should be around 20 to 25 millimeter wide and at least 20 millimeter thick to allow an adequate cortical fixation. So you'll see that we are marking the distal point. Again, it is 2 centimeter below the tibial plateau. So this is the adequate length of the osteotomy, and you'll see that this is the step cut and we are marking our osteotomy site. The next step is to create the actual osteotomy. Now here the key is to be patient, use the saw very patiently, irrigate it frequently, and keep the vibration to the minimum. You'll see that this is how we are putting our oscillating saw here, using and creating an osteotomy. Often if the bone is sclerotic, it's a good idea to use a drill bit to mark your osteotomy site. And once you get this bone marrow, that means that you have cut through adequately. Ensure that your saw blade just exits the far cortex and not completely destroy the soft tissue. The next important step is to actually open the osteotomy. It is important to open the osteotomy in a manner so as to preserve the soft tissue on the lateral side. So you'll see that we are inserting our osteotome here, and very gradually, without breaking, we are just hammering it, and you can see how beautifully the osteotomy site opens up. And you can see that we have preserved all the soft tissue on the other side. After that, once your osteotomy is done, you can proceed with your revision procedure, removing the implants, reaching the access area wherever you need to. And then once the job is done, you proceed towards the fixing the osteotomy. I personally prefer both a screw as well as a wire, because I believe that one device in two different modes, it is much better to have compression as well as converting the tensile force into compressive force using the wire. So you will see I'm putting one screw here at the top. So we are drilling it, almost going perpendicular to the osteotomy site. It's important to have a good tactile feedback so as to ensure that your drill bit is not going too far in the outside the far cortex, and you are inserting 4.5 mm screws, and you will see gradually the compression will start coming in at the osteotomy site. Okay, so you can press it manually, and once you have done that, you can use it a supplemental wire in a different direction, exiting under vision on the medial posteromedial side. You see that I am passing the wire, and once you can see the wire, you can just take it off and then use the same principle to compress the fracture site. So you're just taking off that wire. So a double stranded wires are better. Okay, and you can see that we are just doing this tensioning around here. Okay, once you have done that, you can cut, tighten it further. Okay, and that's it, and you'll see that's a very stable construct. A good end-to-end apposition is important. If you feel that there is, as in this case, you see that there is still some gap, so we can insert one more wire here. And once you do that, it will become rock solid, and you can start immediate range of movement at the knee. Okay, now this is rock solid and the patient can start immediate range of movement. There are certain pitfalls and tricks during revision. It is important to protect the anterior tibial plateau cortex during tibial preparation to avoid spur or sagittal tibial fracture. A tibial augment or sleeve can be used to improve the metaphyseal fixation. The tibial stem should bypass the distal end of TTO to avoid the diphyseal fractures. It is important to be careful with tibial component rotation, because often the tibial tuberosity is used as a judgment for judging the rotation of the tibia. In this case, the foot position or dynamic positioning between the femur and poly can be used, and it is important to avoid cement getting in between the osteotomy site to ensure that it doesn't go into non-union. So reiterating once again, the key steps are adequate exposure, creating a good osteotomy very patiently, carefully opening the osteotomy, preserving the lateral soft tissue hinge, and ensuring a stable fixation to permit early mobilization.